Thank you, Chair. Ladies and gentlemen, it's a pleasure to be here today to open this conference on behalf of the Public Health Agency. This, as Roberta has said, is Palliative Care Week, and it aims to raise awareness of the difference palliative care makes to patients, carers and families. There's often a misconception among the public that palliative care is primarily for people with cancer. This, of course, as we all know, is not true. Palliative care should be provided to all people living with any life-limiting condition. Its purpose is to ensure that the symptoms and the concerns are managed effectively and that the individuals are cared for with dignity and according to their own wishes. Palliative care is the responsibility of each and every one of us, not just those who are health or care professionals working within palliative care. In fact, it is not limited to the health and social care system. As we know, all of us are destined to die. Before that, many of us will care for someone else as they approach the end of their life. With life expectancy increasing and an increasingly aging population living with a range of comorbidities, we must recognize that no one person, no single organisation or service can support all of a person's holistic needs. Optimal palliative care is only achieved through a partnership approach. Improved integration across all services to enhance the provision of palliative and end-of-life care is a key theme of the Transforming Your Care and the Northern Ireland Palliative Care Strategy, known as Living Matters, Dying Matters. Pardon me. The Public Health Agency and the Health and Social Care Board are leading our Northern Ireland Regional Palliative Care Programme, known as Palliative Care Partnership. It seeks to improve the quality of life and the experience for those with end-of-life care needs, as well as those who are important to them. However, we need to look wider than our traditional partners and our current ways of working in order to ensure that each person is cared for with dignity and respect which they deserve and in accordance with their own wishes. Recently, I had a friend who died after 5 months in palliative care, and yesterday I went and had a chat with his widow just to get some feedback, because I think it's very important that we all get feedback from people. And after our discussion, these are some of the questions I would put. Are we confident and do we assure ourselves that the quality of care provided by subcontractors is of an appropriate standard? Are the staff not only appropriately trained, but are they of sufficient experience and maturity to deal with a home which is facing an end-of-life situation? When an assessment is made of the situation in regard to the client, next of kin and carers, is this information always effectively communicated to all those involved in the provision of care, whether they're from statutory body, voluntary body or private sector organisations? In many cases, the family will be expected to deal with a plethora of different providers. We often look to see the extended family and friends, and in this case there was no extended family. It was really just a nuclear family. There was just the individual and his wife with no relatives in Northern Ireland. And in that situation, we have to assure that if there is a single carer, do we proactively ensure that individual has sufficient respite and adequate sleep to deal with the oppressive demands placed upon them? I believe data like that, when gathered and effectively put together, can make a very potent case for additional resources to be allocated to palliative care. A public health approach to end-of-life care seeks to include the community as genuine partners rather than targets of service provision. It aims for greater community involvement in the well-being and care for people with an advanced progressive condition. In doing so, this helps change social attitudes and cultures around death and dying. A public health approach could also meet the social needs to those living with advanced progressive conditions, such as isolation and loneliness, as well as those living with loss. A recent work indicates that people suffering from long-term loneliness can have a very detrimental effect on their health, as much as equivalent to smoking 15 cigarettes a day. In addition to the benefits of a public health approach to end-of-life care, it can also identify previously untapped community resources, which can also help support our clinical and social care services. In an environment of limited resources and competing priorities, evidence on the cost-effectiveness of alternative methods of delivering palliative care is increasingly important in order to facilitate appropriate resource allocation. While palliative care services have been expanding, the application of economic evaluation to palliative care has been slow and the evidence base remains limited. We have to ask ourselves how we can inject some wind into the sails in this area. There is a risk that services which are difficult to evaluate and for which there is limited evidence on cost effectiveness may lose out in the competition for resources to those who have garnered better evidence. Palliative care is one such service. Outcomes are difficult to measure. Furthermore, it can be difficult to assess costs where many interventions work through other professionals and may have large inputs from informal and family carers. Today will be the beginning of more extensive deliberations on how we can work in partnership in order to explore new ways to care for and support people with palliative care needs and those who are important to them. We must not be faint-hearted. We must redouble our efforts. We must be scientific in our approach to data gathering. Having garnered the data effectively, we will then be able to go forth with confidence to compete effectively for the resources which are so rightly deserved by those coming to the end of life, by their family, by their friends, and by their community. Thank you.